This is the Northern Ireland.
Okay, I declare the meeting now open to the public online, and can I welcome members who are participating by video conference this morning. And we have on the line Pam Cameron, our Deputy Chair, and Colin McGrath, I think, is on the line with us as well. And thank you both for facilitating that and allowing us to maintain the social distancing guidelines. Can I remind all members about the protocols regarding the use of electronic devices? We have no apologies received for this morning, and in terms of Chairperson's business, there is no business to report this morning. So moving on then to draft minutes. Item 3, I refer members to the draft minutes of the meeting held on the 24th of September, which are tab 3.1 of your meeting pack there. Are members content with those minutes? Yes, members content, thank you. There are no matters arising from those minutes today. So we move in now to our COVID-19 disease response work, and we are this morning receiving an update from the Minister for Health. I refer members to tab 5 of the meeting pack, which includes a number of items of correspondence, the draft surge planning framework and recent guidance on visiting in hospitals and care homes. Can I advise members that the Minister and the Chief Medical Officer are both here today to update the committee on COVID-19 and other matters. I would now like to welcome Minister Robin Swann to our meeting and Chief Medical Officer Michael McBride. You're both very welcome this morning, and could you just please go ahead and give us your introductory remarks?
Thank you, Chair. And look, I'll keep introductory remarks as short as I can, so we're open to questions and a discussion. So, thank you once again for the opportunity to update the committee. Since my last briefing, we are all aware that there has been an alarming increase in the number of positive COVID cases across Northern Ireland. We saw another 424 cases confirmed yesterday, which is the highest daily total since current testing model has been rolled out. The day before was 320, and that had been the highest ever daily rate. We are facing a very serious situation, and as I said during the media briefing yesterday afternoon, as a country and as a society, we are now very much at a crossroads. If the current trends do not change, if attitudes to this virus do not toughen, then in 6 weeks' time our hospital inpatient numbers will exceed those witnessed during the first wave, and that isn't even the worst case scenario. Our Chief Scientific Advisor warns that it could happen as quickly as 3 weeks. And so to all the doubters and naysayers, I want to emphasise that point. In 3 to 6 weeks, those are people being hospitalised, not people simply testing positive, because this virus still remains incredibly serious and incredibly dangerous. The Executive recently took the difficult decision to implement restrictions across the entirety of Northern Ireland. That followed earlier localised restrictions, which have already resulted in improvements in some areas. Ballymena and BT43 has dropped by about 50%, and the Belfast rate has slowed. But the latter is still unfortunately growing, and we are all well aware of the particular problem in the Derry and Strabane Council area. What we are witnessing there is sustained transmission in the community, and the problem isn't related to a few bad outbreaks. The problem is that the virus is in the community and is spreading rapidly within it. We are now in a place where further difficult decisions are necessary, and as you may be aware, I will be coming to the Executive later today with a set of proposals. As the Chief Medical Officer has said, there's a small window of opportunity for us to stop the spread of this infection. And I make no apology, Chair, for again strenuously urging everyone to do what they can to prevent this virus from spreading further. And those are the simple things that you yourself and other members of the committee have reiterated. Keep washing your hands regularly, wear a face covering, and in closed spaces stay at least 2 metres apart, or 1 metre when a face covering are other precautions. We must all do what we can to stop this now. Chair, I've made this committee aware of my desire and my commitment to restoring services as quickly as possible. Last week I informed the Assembly of the rebuild and restabilisation plans for cancer. It will not be easy, but I suspect there will be political unanimity for what I suspect is a key priority for all parties. However, the pandemic will continue to pose constraints, which are the need to socially distance and the use of appropriate PPE, which will impact on the ability to increase capacity. The current rise in the number of COVID cases will also have a bearing on the level of services that can be delivered in the next 3-month period. I'm already watching the huge concerns as beds and staff that should have been used for more and more elective services are now being stretched to capacity. Achievement of the mission set out in the framework for rebuilding services requires my direct decision making and authority supported by my department. This required, as you know, my department to make changes to the current governance structures which impacted on the responsibilities of the Health and Social Care Board and the Public Health Agency and HSC trusts. This didn't diminish the existing delegation of the department's statutory functions to the relevant bodies, but rather ensured that the direction and oversight of the department's priorities for the next 2 years was made clear. This was to ensure that the planning and delivery of services was designed to deliver the maximum amount of local and regional resilience and ensure the decision making was as agile and streamlined as possible. I therefore published a memorandum to the 2011 HSC framework document which sets out the changes to governance and decision making processes for a period of 2 years, and that became effective from June 2020 and is due to be reviewed on a 6-monthly basis. When I published the memorandum, I undertook an initial sounding exercise to which 36 responses were received and gave the undertaking that my department would undertake a full 12-week public consultation exercise in line with its statutory obligations. That public consultation was launched on the 14th of September, and I'd be happy to provide the committee with progress reports on that issue. Chair, I'm now open to questions and comments.
Okay, thank you very much, Minister. And I would like to begin by just acknowledging the work that yourself and all of your team have been doing in the efforts to tackle this pandemic and the serious issues that are out there. There's clearly no respite in terms of how this is progressing, and the pressures look set to be increasing and at this present time, which is a concern. I would like to welcome your confirmation that a COVID life assurance scheme is now in place. I think that's very useful, and I also note that you are making further inquiries in relation to the impact, to ensure that wouldn't have an impact on benefits. So at the committee, on behalf of the committee, I'd like to welcome that. I'd also like to welcome the written statement that was made to the Assembly. I think that's useful in terms of keeping everyone updated and that people are aware of what's happening at any given time. And I do understand that your time is tight this morning, and we appreciate you coming, and we will keep the session as tight as we can in terms of that. I would also want to reiterate, given the very worrying times we have, those messages that we have stated in the past, the simple but so important things about washing hands, wearing masks, cough hygiene and social distancing. And in fact, I would ask people to abide by the regulations and the guidance and advice as a minimum, but to indeed go beyond it if you can. If you can do something further and over the next period of time to reduce your contacts, which would appear to be a key driver of the increases. So I would ask that, and I would acknowledge the fact that most people have been doing that, and that is important, and it's going to remain important in the time ahead. So while we're asking people to do everything they can, I think it's also important that we ask ourselves and we ask the system, is the system doing everything it can from what it provides to meet the needs that we face? And I have recently spoken with the contact tracing team. I just do want to give a mention to the number, because I am concerned that they told us that between 5 and 30% of calls are not at times answered. And the number that they are calling from is 028 9536 8888, and I would ask that people bear that number in mind. I think that people should be conscious that could be the call they're getting, and it's very important information. I am also conscious of significant issues and widespread issues, and I am doing some work myself on this, but in relation to testing and people not being able to get testing or not getting test results back in a timely fashion, which is obviously creating a window of doubt. And I know the advice is that people should self-isolate until that comes back, but I think it's crucial. So in light of that, can I ask, Minister, are you concerned about the ability of the testing and tracing system to cope at the minute? And what steps did you take over the summer to ensure that we have a robust and a fit-for-purpose system in place?
I'll start with the testing and tracing. Chair, we have seen an enormous amount of cases coming into that system. And as you rightly say, each positive contact is followed up at least 5 times, so they can try to make a contact to that. We're at 123, 125 full-time contact tracers. There's a recruitment process, has completed, I think, again this week for another 30, which have completed their training, and there's an open recruitment call, which should see another 20 coming on board within the next week. We've taken over now a second floor within County Hall in Ballymena, because what that facility has allowed us to do is actually utilise small offices, so we can actually work individual teams as bubbles. Because one of the things that we were concerned about, and I think it was something actually Pat raised in the chamber at one point as well, was about the location. If everybody was in the same locality, if a member of our contact tracing team became positive, it could take out the entire system. So we've built in those protections. One of the things, or one of the small changes that has been made that we hope will ease that number of calls, was last night the PHA announced that additional contacts will now receive a text message rather than the call. So whoever tests positive gets the call. They give their contacts. If they give mobile numbers, they get the text message from the PHA, the same as our app there, so they get that sort of same information. In regards to the technological advances, our app is working well. Over 400, just approaching 400,000 downloads. Has activated, I think, just in the region of 2,000 additional notifications for people, to take the appropriate action. I hope by the end of this week, in fact, I'm near enough sure by the end of this week, we'll have the under 18 version launched as well. And again, Chair, going back to when we talked about apps in here, there was two pieces that was critical to us. Was the data protection issue of it. We've secured that, but also the cross-border interoperability. And as we see the increased numbers in Derry and Strabane and other border locations, the ability for our apps to talk with the one in the Republic of Ireland is crucial. In regards to testing, we keep pushing our own internal Pillar 1 testing capacity and using our partners that are there, but also accessing the Pillar 2, which is the national testing. Now we're working to make sure we can get test results back from it as quick as possible. Just to put things into perspective where we are in testing, Chair, a piece of work, I think it was actually in response to an AQW for the period between the 9th and the 15th of September, were tests per 100,000 of population. We were sitting at 348 tests per 100,000. England 325, Scotland 289, Wales 298, and the Republic 220. So for our testing capability using both our pillars, we're testing, a high percentage of people, and that's, I think, it's proven its worth in regards to the positive cases that we're seeing coming through.
Okay, and I did note last night the text system coming into place, and I suppose part of, while all the different strands are obviously useful, part of the concern around that would be that the very detailed information that you need, well, first of all, from the point of view of supporting people and that human-to-human contact, but also there has been a case mooted there recently in the south, I think, where one case, and they had contact traced it out, where one case had generated a further, I think, 30 through a variety of, and that the rich detail that we need, because part of this, the entire system here needs to be about find, test, trace, isolate and support. And in terms of the finding, if we don't have the capacity to track down and to find that type of detail, is it a sign that the system is under pressure, that they have had to go to texting? Is that a sign that we are facing into capacity problems?
No, I actually think it's utilising the technology that we have, Chair, to make that contact. We've seen it working through the app, so it was taken that PHA took that decision to see if it would be of a use. Actually to get those secondary contacts as well. So just it's not to short circuit it, but it does take time to make the 5 phone calls that you yourself referred to. People maybe not answering a number they don't recognise, but you read a text. So it is about that, trying to get whatever tool we can possibly get to make sure anybody who has a secondary or a tertiary contact actually gets the information they need. Michael, do you want?
Yeah, no, I think Chair, it actually addresses the problem that you mentioned about the timeliness of the contact with individuals who need to self-isolate. So what we do know from the contact tracing service is that 95% of the index cases are able to provide contact numbers of their close contacts. So we have that information, and therefore it's important that we get that information out to those individuals who need to isolate. And the text messaging and using of SMS texts is a rapid means of doing that. And unfortunately, as you said, sometimes there's a high percentage of the first calls, or indeed the second or third calls, that are not answered. And this is a way to circumvent that. I think that the other thing to mention is that the text will also provide a link to the COVID Care app, which provides tailored advice in relation to, if you get symptoms, what to do. And I think the really important message to get out from here today is, if you get that text message saying you've been in close contact and are asked to self-isolate, it doesn't mean you need to go and get a test. What it means is you follow the advice, you self-isolate, and if you develop symptoms, then you get a test. So that's crucially important. Now, that information is obviously contained in the link to the text, but it's important that we ensure that, as you quite rightly point out, with the pressure on testing, that we prioritise testing for those that are actually symptomatic, and we've been putting that message out for quite some time. It's when people are symptomatic, or indeed they're advised by the contact tracing service or public health agency to get a test, that they should get a test, and not in other circumstances.
Okay, thank you. And I am conscious of the pressure of time, but I know I have a number of questions, and I think other reps would have questions in sometimes that don't get answered, and we all understand there's huge pressure on time. I have asked some questions around memorandums of understanding, because it's clear now how vital that North-South cooperation is. I have also asked questions in relation to the surge planning, and we're now on the 1st of October, and we're looking obviously at a very worrying situation. So in terms of the surge planning, what update can you give us in terms of the work that is in place for a very difficult winter as it now?
Well, we're looking at, we'll be publishing our next 3 monthly surge plan by the end of
October, December, well,
Aye,
October.
where are we? Aye.
October, so I'm trying to work out the months.
I
Yeah,
can't
sir.
remember what three-month period we're in.
October to December.
That works actually with the management board at the minute to sign off in regards to make sure that we can keep as many services open as possible, and that's why we did the piece of work on cancer, palliative care, surgery, orthopaedics, moving to that more regionalised hub. I met with the board of the South Eastern Health Trust yesterday in regards to the work that's going on in Lagan Valley, and getting very good reports coming out of there of how they've been able to reconfigure buildings, services, and people as well, to make sure, Chair, if we do need the bed capacity for COVID that we did at the start of this year, that a lot of those services can continue, because that was one of the things that we have learned, was stopping those services completely made them very hard to restart, and we're all aware of the implications that they've had. So it's about trying to run, and I think I've said this before, Chair, I've said it in the chamber. When I took over in January, we were running a transformation health service to try and deliver some of the changes of Bengoa, plus keeping the health service running. We're now trying to run 3 health services, so we're doing some of the transformation work, we're trying to keep our health service going, plus we're doing a COVID service as well, on the same footprint with the same number of people. So the surge planning is about that strategic look. Our regional approach and the network approach that we're seeing across a lot of the specialities, because of the silos being broken down in the last 6 months, is really embedding and really getting good feedback from staff, from trade union side, but also from patients as well who are utilising the service.
Okay. Well, finally for me, and I suppose in relation to that, I think everyone did understand that there was unprecedented things had to happen at the start and all of that, but I think there is an expectation, rightly from people, that lessons will have been learned, and that we can do things better this time than potentially we did before. And just in relation to that, and a very quick response, please, in relation to the surge planning, either today or come back to us if you don't have the detail, but in terms of the ventilators which we have talked about before, how many ventilators have been ordered, how many have been arrived, and how many have been commissioned?
Off the top of my head, Chair, I don't know. I know we're well into the nearly 200 in place and another 200 still in progress. So we didn't stop buying. We kept any orders and any progress we had still in progress. I don't have it off the top of my head.
How would provide an update on that? I mean, we have capacity, through the Nightingale 1 to significantly expand critical care capacity with ventilators aligned with that. Again, just to correct my earlier comment, the rebuild plan is from October to December. The surge plan is from October through to March. So we're looking at the surge plan to get us through to the spring. And obviously it include issues such as the Nightingale 1, which was the step up in intensive care, but Nightingale 2, which is the step down facility in White Abbey, to make sure we can maintain patient flows, and then to continue the separation between COVID-free care, in terms of elective care and other services we need to maintain. Unlike last time, we're going to seek, as Minister said, to maintain routine services as far as that is possible, while at the same time maintaining the services for those who need hospital care for COVID-19, with enhanced support to ensure we can support people who are not ill enough to require hospital admission in their home environment, with obviously liaison with primary care and with respiratory units in our hospital settings.
Okay, thank you. A detailed update on that would be useful.
That's fine.
So I'm going to go across to members now. I'm going to go first to our Deputy Chair, Pam Cameron. Pam, are you able to hear us there okay? Yes, Pam, can you hear? Pam, can you go ahead there with the question? Yeah.
I can now. Thank you, Chair, and thank you, Minister and Dr. McBride, for your attendance at committee today. Just on the outset, I want to welcome Robin, and particularly your comments around keeping services open as much as possible. I think it is vital that happens in any second wave that we're entering now. Just on the back of comments around the testing capacity, are you concerned that schools, children and staff are being tested unnecessarily and putting additional pressure on the testing systems? That would be my first question. And my second question would be in and around, and you'll be well aware of the attitude that some members of the community are taking in terms of COVID-19, where complacency seems to be rife in community. The merits of a mask actually adhere to restrictions. I know from a family member and from what she has told me working in ICU what that entails, and quite frankly it is frightening. And I would like to ask maybe Dr. McBride, could you possibly outline and give us, even if it has to be graphic, let that be the case, but an average experience within an ICU department if you are unfortunate enough to have to be admitted to receive that treatment, and how the virus attacks the human body. Thank you.
Okay, Pam, I'll let Dr. McBride pick up on that last one from a very specific medical point of view. In regards to teachers and pupils, I think the work that we have done, and even recently in regards to making sure we're getting the right message through to principals and parents in regards to testing, to provide the reassurance of what steps they could take. And I think the Education Minister said at the start there would be bumps. There were bumps in regards to that guidance and advice. That's why PHA set up that specific call cell the school principals could use should they need to seek further advice. If someone has symptoms and needs to be tested, I would advise them to get tested. But if the guidance said that they should, I think as the Chief Medical Officer said, if the guidance says you should self-isolate for 14 days before symptoms appear, I think that's the guidance that we would ask people to follow. That's why that guidance was developed, to ensure that our testing capacity is there for those who need it when they need it. But I think we've done that piece of work with schools and with parents of a very clear flow chart of what steps parents should and teachers should take in seeking a test and when to seek a test. Michael, do you want to pick up on the ICU experience?
Yes, happy to do so. I think it's very difficult for people to imagine what it's like to be fighting for your breath and not being able to breathe, and how scary an experience that is. I think it's also doubly frightening if you think back and try to imagine what it's like to be in that situation where you're separated from family and from friends, from your normal sources of support, those that would provide resilience perhaps and encouragement at those times, and the only interaction that you may have with those individuals, if you're in a ward environment, is via technology, Facebook, or some other means by which the ward staff, doctors, the nurses, all of the allied health professionals are trying to ensure that you can maintain that contact with your family and indeed with your friends. You will be in a ward environment in the first instance, and you may be having support with your breathing. So we talk about CPAP, continuous positive airway pressure, and that's to help ease the work that you're doing in terms of trying to get air into your lungs. That in itself is a very traumatic experience. You've got a mask tightly fitted over your face, which many people find quite claustrophobic. You need to maintain that mask over your face, otherwise the amount of oxygen, your oxygen saturation falls very, very quickly. And it's a bit like facing into a wind tunnel. So you've got this air coming at high pressure, forcing air into your airway. So it's a very, very unpleasant experience. But what you know is, as an individual patient, as a person sitting there, that it's the difference between you keeping well, staying well, and perhaps ending up needing to be transferred into intensive care. And all the time you're surrounded by doctors and nurses whose hands are gloved, whose faces are behind face masks, who are wearing PPE. So despite the best efforts of staff, it can feel a very impersonal situation at a time of significant anxiety and significant fear. And then, despite the efforts of the medical teams, and despite the use perhaps of some of the new drugs which we're seeing that are effective in terms of people requiring oxygen therapy, the dexamethasones, the prednisolones, the new investigational drugs, the remdesivirs, for instance, there'll come a time for many individuals, sadly, where the conversation has to be had that they need transfer down into an intensive care unit, because we know that early ventilation in patients who are deteriorating is important. And then comes the conversation which has to be had with those individuals, that once they're ventilated, they might never wake up again, because it may not ever be possible to take them off the ventilator. And then they have a conversation with their family again, not directly, because that's not possible to protect family members, and they have that remotely. Again, with members of staff in PPE, full PPE. So again, that detachment, although still a hand and there's still a smile behind the mask. Yeah. So it's a very, very scary experience. And when individuals are paralysed and ventilated, they don't know whether they're going to wake up again. And their relatives don't know whether they're going to wake up again. And sadly, for too many, they don't. For some, the course is one of an improving one, but many people are left with long-term sequelae, both psychologically, from a mental health point of view, and respiratory problems. And we've heard of long COVID. Sadly, many people in that situation get some of the other syndromes that we know are associated with SARS-CoV-2. So in addition to the respiratory problems, they get an immune response to the virus with chemicals called cytokines and others that flood their immune system, and they develop clotting problems, they develop renal problems, and despite the best efforts of the skilled multidisciplinary team in intensive care, sadly people die. So that's the reality of COVID-19, and I think that's, I think we saw that in wave one, and I think that's the reality none of us should lose sight of. And as the Chief Scientific Advisor advised yesterday, we are a few short weeks away from that reality again. And as Minister indicated, we're at a crossroads. We have weeks to intervene. It's back to your point, Pam. We all now need to do the right thing. And as you said, Chair, it is about us reducing our social contacts. We are not powerless in all of this. It is not inevitable. But unless we all act now, the consequences and what we will see in the weeks ahead are actually very, very clear.
Yeah, and I think no one should be taking a chance on experiencing those or passing on the potential for others to have to experience that. So that is Jerry.
Thanks, Chair. Thanks, Minister and Michael. A couple of comments from yourselves. Obviously, we had a discussion last week about the review into neurology, and a few patients have been in touch with myself and other members, and they're still concerned that there hasn't been a follow-up meeting from the department, and they've expressed to me, and I'm sure others as well, their real trauma. They're hearing about resignation of Dr. Watt last week, and there's a concern that they're not being listened to or consulted with or talked to. So that's the concern I just want to relay, and a response would be useful from the Minister. I've also been told that there may be, and I would seek some clarity on this, there may be an increase in assault on staff in working in the learning disability sector. So I'm not sure if the Minister or the CMO has any figures on that, but that would be a concern that's been relayed to me. And also, obviously, maternity services, we've been in touch by a lot of people about concerns of partners being unable to attend.
Jerry, we're on quite a so if we can just wrap up we can only take a question or two each. We can't. Right, okay,
so, I'm not sure. Sorry. Okay. So maternity services, obviously, there's concern about that, and people feel that they can go into the restaurants and bars, but they can't take partners into services with them for support. So just a comment on that as well.
Thank you.
Okay. I'll give some of those quickly. Just in regards to the maternity, the visiting guidance across our whole health and social care sector was updated on the 22nd of September. That has moved, well, on advice from Chief Nursing Officer and her team, that we moved to stage 4, which is a more intense, more restrictive access in regards to specifics to maternity. The revised guidance is applicable to women either while they are an inpatient or antenatal, postnatal wards, or attending the maternity hospital for the following reasons: 12-week scan, early pregnancy, anomaly scan, attendance of fetal medicine department, pregnancy loss and bereavement, and for the duration of labour and birth. So that guidance is updated. It's on our website. I'll send it across to the committee chair so it can be circulated, because I know there was a narrative started around what was possible and what wasn't possible. The Chief Nursing Officer has done some messaging around clarifying exactly what is possible, and it's, when a woman goes into a side ward or a single ward for labour, the partner can't be there for the duration for a number of scans, but we'll forward on that specific guidance that was updated. In regards to additional attacks and violence in regards to the learning disability sector, I'm aware, Jerry, but again, if you can provide me with information specifics, we can follow up on that. In regards to the neurology recall, again, the Chief Medical Officer has led on that. He's met with a number of the charities recently.
Yes, 18th of August.
18th of August, and that was the last update. Maybe, Michael, do you want to give a brief summary?
Yes, I think, and thank you, Jerry, it was a matter you raised many meetings ago in perhaps more normal times, and there absolutely is a commitment from the department, from the Minister, to engage with families broadly, and we have had engagement with the neurology charities, as I said, myself and others met with the charities on the 18th of August. I have to also, though, note that obviously the charities don't represent all of the individuals that have been caught up in the Neurology Recall. I again want to acknowledge the pain, hurt and concern and ongoing anxiety that there exists. I think the difficulty with, obviously, in terms of the neurology process itself, is that because of COVID, elements of the work that would be further progressed by now have not been progressed and have been paused. We have, again, recently recommenced that work. As I say, there is a commitment to engaging with the families affected. The challenges will be how we would do that currently in relation to the current situation in terms of community transmission of COVID. But there are means to do that, using technology, and I think we do need to explore how we do that rather than allowing a further period of time to elapse. Obviously, it's not as satisfactory as doing it face-to-face, but perhaps there may be a combination of face-to-face, such as we are doing today, plus others who perhaps can connect into that more remotely.
Okay, thank you. Alex?
Yeah, thank you for your presentation. Can you tell me, just to get clear in terms of face masks, who's responsible for enforcing face masks being worn in businesses? Is it the businesses, police, or the council? No, I do know the answer, but I'll need you to clarify it. That's my first question. Second question is, what plans have you to tackle the huge increase in coronavirus cases in Strabane and Londonderry? I think that needs to be dealt with quickly.
Thank you. Thank you, Alex. Thank you. Yep. Go ahead, Minister.
Okay. Look, Alec, in regard to your second point, the increase that we've seen in the Strabane and Derry City Council area, I think, has been stark. It's been dramatic. It's not something that we were expecting, to be brutally frank. We have further recommendations going to the executive this afternoon for specifics in that area. Chair, I never have broken that level of executive discussion prior to the executive having it, so I'm not going to do that. But I expect, Chair, there will be further announcements later on today on the back of our recommendations. In regards to face masks in retail, already it's a law that has been passed and is in regulation. The police have a responsibility. I know it's one they've been reluctant to use to date. You may be aware that the executive has set up a subgroup on compliance and enforcement of the regulations and the legislation that's already in place. That's been led by the two junior ministers, has representation from local district councils, PSNI and a number of other statutory bodies, so that we can really get that message through. It is one we never wanted to have to utilise, to be quite honest with you, that would have to go down that length. But when we're seeing the levels of non-compliance that there will be a step where we'll have to go that, or also adding further regulations or recommendations where face coverings should be worn rather than just the settings that we currently have.
Yeah, I mean, I think back to the Chair's comments at the outset that, we don't need to wait to be told to do the right thing to do the right thing. As you said previously, Minister, we can't police or regulate this virus out of existence. I would encourage everyone, when in an indoor environment, to wear a face covering, and that includes those settings where it's currently not regulated that they do so or mandated that they do so. So if you're sitting in a restaurant and you're not eating, if you're in a restaurant, you're not eating and drinking, and you get up to move around or to use the toilet facilities, wear a face covering. If you're in a shop, a retail environment, you wear a face covering. And if you're in public transport, you're mandated to wear one, as you are in the retail sector. I think we've all our part to play. I think first and foremost it's all our responsibility. Shops, and retail sector can decline entry to people. Indeed, some are already. I know some of the big supermarket chains have taken action to do that recently. And also where there are challenges, obviously, and in non-compliance and regular non-compliance, the police have a role. But I do see that, my own view, and I'm probably straying outside my responsibilities, it isn't first and foremost a responsibility for the police. The police do have a role. It's our responsibilities to do the right thing as citizens of Northern Ireland, to protect our family, our friends and everybody else.
Thank you. Pat.
Thanks very much, Chair. Thank you. And just on the issue of COVID and the transmission, it's clear from the South statistics that have come out that it's the deprived areas that are most affected, the Tallaghs, the Ballymuns and so on, and it's the Killineys and the Black Rocks that have the least infection. What measures are you putting in place to ensure areas that are disproportionately affected are going to get the greatest amount of support?
Pat, we're seeing the same evidence here in Northern Ireland as well, and you'll know that from what we're seeing in Belfast when we're going to postcode restrictions. And again, it's making sure that there is accessibility to testing. It's also to make sure and have the conversations with our GP colleagues in those areas that they can supply the support that they need. Also working with your own party colleague as for the Minister of Communities, and making sure that we have the additional support packages that were there during the initial phase of lockdown are still there to support communities as and when they need them. But I think it goes back, it's that accessibility to the health service. It's equal accessibility to the health service, no matter what postcode, no matter where you are. And again, working through and with the Department of Education, making sure that any health messaging that we're putting out is also being utilised, and the children are taking it home as well to their parents to make sure that we're getting that message through. It's also again to make sure in those areas as well, we're also aware of ethnic minority populations as well. So the PHA are engaging with ethnic minority organisations, translating our guidance into a number of different languages as well. I met with the Polish consul yesterday to utilise his offices because we are aware, we can put out as much messaging as we want, even through this forum, even through our TV channels or newspapers, but there's a large section of our community and our ethnic community as well who aren't utilising that channel. So it's imperative to us that we use every access and any availability that we can to get our health message through.
And just in terms of accessibility to the health service, I mean, we had a debate during the week about the issue of children with hearing difficulties accessing tests. We had the news yesterday, 30,000 women have missed out on breast screening since the pandemic started. And you know the case because you have communicated with a family, a young woman with endometriosis who's in excruciating pain and can't get surgery. And the difficulty is that a lot of people are saying we now have a COVID service, that we don't have a health service unless you have some sort of immediate life-threatening condition. It's very difficult to get treatment. And when can we expect for normal service to be resumed?
Pat, I wouldn't have an answer to when normal service resumes because that's to do that we'd have to say COVID has gone away and we're not putting the resources we need to support those patients that are coming forward with COVID. What we are doing in regards to the surge plans and our 3-monthly rebuild plans is trying to open up as many services, as many locations as is possible, as is safe to do so. And as I said, in the Chair's opening comments, in January our challenge was to be running a transformation service beside a health service. We're now trying to run a transformation service beside a health service, beside a COVID service. I'll not deny that is main part of the work that we are doing as a health service. But I'm still working with this reduced number of staff. We are recruiting, but it takes time for those people to come onto our front line. We're working with a tired workforce. So they were tired in January. Went through the first phase. They're still tired now, but they're there, they're dedicated, and they want to deliver as many services as we can safely deliver. So that's why I said, come back to the comments with the Chair, that's why we're looking at those different approaches. The orthopaedics, the elective daycare surgeries, our cancer rebuild services as well. It may mean people have to travel to access that speciality or that specific, but it's what we have to do to try to deliver the service.
Yeah, sorry.
If I could just make a quick comment.
Very quick.
The difficulty is that a lot of people don't understand why the services aren't available. In some cases they hear surgeons are willing to move in and operate now, tomorrow or whatever. And there are other services that have been suspended and people don't understand why, except with the broad brushstroke that people are needed in the front line. If there was greater explanation as to why these services have suspended, people might be more understanding.
Yeah, no, I think that's a fair point, Pat, and I think it goes back to that point. The surgeon may be available, the waiting room, the nurse, the cleaner, are all somewhere else. So it's the strength and the weakness of our service that it is reliant on everybody who's a part of it. It's just all the one individual.
Just very briefly, just on that point, I think, Pat, if it would be helpful, I think that what we primarily and must do is provide a service that's safe for those who need access to it, and notwithstanding the fact that people need access and there's an immediacy and a challenge around the delays that people are experiencing, but it has to be safe for the individual patient who needs the treatment or a screening test, and it has to be safe for the healthcare professional. If we take, for example, screening services, there are 28 work streams under the Rebuild Programme Board. The rebuilding of screening services is one of them. The throughput through screening services is reduced by 50%, and that's because of the point that Minister has made between a number of people that you can see in a particular clinic, the time that needs to elapse between individuals, the donning and doffing of PPE by staff. And what we've taken is a risk stratified approach, for instance, in terms of screening, where we look at those at highest risk, so that actually we can prioritise those. We're not going to be in business as usual for many, many, many months, and I think Paula had asked that question some health committees ago, until such times as we have a better control on the virus.
Alan.
Thank you, Chair. Minister, last week we had a presentation from a professor in Hong Kong who told us about the good outcomes that they had had in relation to COVID, and it was because of the lessons they'd learned from the previous devastating SARS outbreak that they had, so that created 1,400 isolation rooms in their hospitals. They had no shortage of PPE, and they had intense ongoing infection control training. Now, we all acknowledge that the NHS wasn't really in a very good place in the early part of this year, but how much additional pressure did the inadequate backup stocks of PPE and the availability of ventilators in the early stages of this outbreak create for your department? And how would you describe what your department and the staff throughout the NHS at all levels have achieved to date in dealing with this infection?
And very briefly, if I could, as part for
Alan, in regards, and I think it goes back to the Chair's point, you know, there was a clamour worldwide for ventilators. We never got to a point where we were looking for a ventilator. We had enough, but we're still buying more to make sure they're there. In regards to PPE, I think our challenges are well documented on PPE. We had 4 weeks supply, which was normal process, normal usability, and we went through that in a matter of weeks. We've now moved to having a 12-week supply, which is pandemic level supply. That's what we're maintaining, and that's what we're going to maintain, because that's what we have to maintain. You know, we had challenges with PPE. We got to a place where we were able to deliver it in a better place for our care home sector, for our GPs, and for our hospital provision as well. In regards to isolation rooms, I would love to have had the estate and inherited the estate that it sounds as if Hong Kong has. Hong Kong probably has that estate because they've learned over time, and I think the learnings coming out of this is to look to our estate that we have, where it is, what it's been utilised for, and what work needs done on it.
Okay. Thank you. Going then to Orlia.
Yes, thank you. And just on to follow on from Alan's point, the presentation that we got last week, I don't know if you picked up, but Hong Kong are also using one model of one model of a testing kit, whereas we're using different models. So I don't know if that's something that the department's looking into. But my first question is around, there was 2 quite significant issues that have arose in the Health Committee over the past couple of weeks in relation to legal advice, and the first one was from the Chief Pharmaceutical Officer, who, in relation to the internal market bill, the committee had asked a few questions on if she could give any guarantees that there wouldn't be a knock-on impact on medicine shortages in the future here in the north. So I know that she was taking that away and that they were awaiting legal advice. I'm just wondering if there's any update on that. And the second piece of legal advice was around, we had a briefing from a departmental official last week around data sharing between north and south. And I know that there's been some difficulties and issues with that process, and there was a meeting with the legal team last week as well on that issue, so I'm just wondering if there's any updates on those too.
Those are detailed questions. In regards to the internal markets bill, I have a letter to FM and DFM in regards to where we are as an executive on that, because it's not solely as the Department of Health. It's actually gone through our EU process as well, so it's been raised through the EU committee of the executive. So that letter has been away to them, asking them to look for a 12-month derogation of what we currently have, so we don't have those problems. That letter's just away. I've had no answer for feedback from it, but Chair, I'll make sure that the committee is copied in any regards to any replies coming from that. In regards to the data sharing from north and south, there was a meeting last week, because we had received input from the AG, or in the Republic of Ireland, that they didn't think it was legally possible at that point. They were looking to see what work needed to be done so we could do that. The North-South Ministerial Council meets tomorrow in health format, so that's myself and Stephen Donnelly and CMO, so we're expecting an update there as to what we need to do to progress. We have a good working relationship. I think it's legalities rather than rather than any will from the Republic of Ireland, from either their health department or their HSI. So I don't think there's any reluctance in doing it. I think it's just the practicalities and the legalities, but we're working on that. I don't know, Michael, if you have a...
No, I think that we have sort of differing legal interpretations about the ability of, I think the Attorney General in the Republic of Ireland appears to be quite clear that unless it's for a particular purpose, in that the information is obtained in the Republic of Ireland and for utilisation in the Republic of Ireland, that the current situation is they're not able to share that outside. I think our advice is that there are exceptions to that, so both legal teams are discussing that to get that issue resolved. So it's a legal matter, a technical legal matter, which is well beyond my competence, I'm glad to say, but it does need sorted.
Okay.
And just my second question, very quickly.
No, earlier, sorry, I'm going to have to move. I only have time left for other... You had two there, so go ahead, Paula.
Thank you, Chair. I just want to come back to the issue of companionship in the maternity services. Let's get this wee message up here. I got this from a constituent last week. Girl is in EOU, as you know, that's in the Ulster herself. Baby's heartbeat isn't strong and she has asked for a few times if her partner can come in while she's crying, but they can't let him in. Heart's breaking for her. I have a constituent who had to drop one child off to say goodbye to the mother, and he drove to McDonald's and pretended that this was not happening, that their mother was passing away, because they could only let one of the children say goodbye to the mother. I mean, I could read out 100 emails of the really horrendous situation that people are in terms of not being able to be with their loved ones at these critical times. We are storing up a mental health pandemic around the trauma that people are enduring because they're not able to see their loved ones in these times of birth or traumatic antenatal appointments or end of life. This virus obviously is going to be with us for some time. What are you doing around home births or palliative care at home or other ways in which people can be with their loved ones when they need to be? Because it's just inhumane, the situations that people are being put in.
I would say, Paula, this virus is inhumane because it kills people. The guidance that we've put into hospital visiting is not something that my department took easy. It's not something that was easily recommended by the Chief Nursing Officer and her team, having went through all those different scenarios, because our Chief Nursing Officer and her midwifery team and the team who draw up these guidance and recommendations have been there at those bedsides, have been there at those wards before the pandemic and have experienced this. So this isn't for ease that we brought in these recommendations on hospital visiting. It's to make sure that we can provide as safe a service as possible to the people who are utilising it and for the people who work in it. We've already seen, unfortunately, in the past number of weeks outbreaks in hospitals settings. It's not something that we want to see in an antenatal ward. It's not something we want to see in a maternity ward as an outbreak of COVID-19. So when these decisions come forward, they're hard to put in place because we do know of the effects that they do have. But in regards to proportionate of what we have to do to provide safety in a workplace setting to family members as well, it's what we're there for. It's what is recommended, and that's what we've brought forward, and it's what I stand over. You know, for the emails and the messages you've got, I can assure you I've got them too. They're heartbreaking to read. They're hard to read. But when I get that advice and guidance from my medical team that says this is proportionate for what we have to do, I accept that advice because they're the experts in this.
But are you looking at any alternatives, like them being able to put on PPE, home births?
Yeah, in regards to PPE, you know, it is about the utilisation of PPE in those scenarios. So in regards to palliative care and end of life, there is a support mechanism and it's a specific section in the hospital guidance, as well as maternity services as well. As in providing, you know, that palliative support at home, you know, it was Palliative Care Week last week. There are organisations on a part of our department and health service that actually delivers that for people who want it. It's not, it's not something that everybody actually wants. It's not something that we can support without the additional resource that we currently do not have. In regards to home births, there are, I suppose, a number of cohorts, a number of midwives who are there to support that, but in very specialist circumstances. Michael, do you want to?
Yeah, look, I think
Very briefly, Michael, have another member.
Very valid points. I think it's about achieving a balance with a responsibility to recognise the points that you make, that visiting is hugely important. That's why we have maintained visiting, and there are exemptions in terms of palliative and end-of-life care within the guidance which I'd refer you to. We've also maintained visiting into care homes because we know that the real harm that comes to older people, particularly those with dementia, who are deprived of direct face-to-face contact, and we've put precautions in place. Throughout all of the pandemic, women who have been in labour, there have been arrangements in place, or attending staging scans or fetal abnormality scans. There have been arrangements in place where partners can accompany them. The enemy here is the virus, and what we try to do in all of this is actually balance the risks, not just to the individual patient who may be in a ward or in a unit, but also to the other patients who may be there when there are visitors. And it's a difficult juggling act, but it is one that we can't duck. And I apologise for the distress that's caused, but we are trying to do the right thing to keep everybody safe.
Thank you. I'm just checking in with Colin McGrath, who's on the phone. Colin, are you there?
Yeah, indeed. Thank you very much, Chair. And I suppose, Chair, at this stage, as I'm at the end of the list, it's really just one or two comments rather than specific questions, as much has been asked. I suppose I'm the living embodiment of the COVID app actually working. I got the alert on Monday during the Executive Office statement, and then immediately left the building and came home, and I've been in isolation since, and will be until the 14 days pass. But I suppose the comment on that really is, I did have a number of questions later that evening, and things were going through my head, and I did find it very difficult to find the information. I tried ringing the helplines, and they rang out, and I searched through the internet, eventually found some of the information that I was looking for. But something that I had previously asked was, from one department, was for a very, very simple flow chart. And it was in fact for businesses in terms of being able to find out what they should do if a member of staff had COVID. That was published this week, and the business sector have been saying that they find it incredibly helpful. It's very clear, it's very concise, it's one page, they look at it and they know what to do. Does something like that exist for whether you think you've got COVID, whether you've got symptoms, whether you've been told to isolate, what you should do, and as a simple graphic? Because many people are visual and will look at an image and trace it through and then know exactly what they have to do.
In forms of a simple graphic, Colin, I'm actually going to say no, I don't think there is. But there will be shortly. And I think that's, it's about the graphic, it's the flow chart, it's the easy step. I know it is there and it's on the app, so it's easily accessible and followed through the app. Takes you through steps and stages, but not everybody's utilising that guidance or advice, or seeking that guidance and advice through the app. Something we'll follow up on.
Okay. And also, just there was mention about the text messages going out, and I appreciate that because of the sheer numbers. If we look back to 2 weeks ago, where there was maybe 30 cases a day, and now there's nearly 300, of course that staff are going to be under a lot of pressure. And I know that the people, there's been a bit of a spike within my area, and as a result, lots of people are getting the messages and getting the updates. And I know that the contact tracers are maybe not. I know one person that's been nearly the best part of 48 hours now and hasn't had any contact from the contact tracers, so the text message would be good, but I do think there needs to be a dedicated person at the end of a dedicated phone line, that if you get that message, that you can ring them and get some information. And just finally, I'll echo what Paula had said and others. I've been contacting people about particularly the end of life as well. People feeling it's a very, very traumatic experience. They're not able to say goodbye. And if there were other ways of helping people in that scenario, it would be really, really appreciated. Thank you, Chair.
Okay. Okay, I suppose I would just like, and I appreciate that this morning's has been a very tight session, and hopefully we will be able to get into some more details. I would just like to reflect when you are here that we have ongoing concerns around the level of information that we're getting in terms of SRs and our ability to scrutinise the restrictions and the regulations. So I do want to flag that up as a concern. And also, just if you quickly, as a final point, this current surge, what's your analysis of what's driving that? What's the key issues behind that, and what's the key things people should do?
Chair, if you have specifics on information for the SRs, if you can get it to us, because again, it's part of the complication that has developed, because these are health. They're all coming through. They all come through the health department. They all come through you as a scrutiny committee, but some of the decisions are actually without. We have raised detailed issues with your officials, so they should be aware of the information we're looking for. That's in the system. It's the problem is we haven't got it. Right, that's all right. We can follow up on those. Where we are and what's driving this, it is community transmission. And I think in the Derry City and Strabane Council area, it's small numbers of social clusters, and by small it's 5 and less. Now, we can only garner that information by what information people give to our tracing team. So if people aren't forthcoming, we can't capture it. So that's why we have that specific list that our contact tracers go through and ask, in regards to their activities and what they've done and where they've been. So it is, as far as we can see, it's community transmission. There's nowhere, and I've said this before, Chair, there's no one business, there's no one industry, there's no one locality that we can point to and go, it's that. If we could, it would be easy to control. We did see that at one point in BT43, where we had an outbreak associated with a meat factory in the community around that, so we knew where to target focus. We saw it in the early days, I think was in Limavady, around a specific karaoke party, because everybody told us that's where we've been, and we were able to expand from that. But from what we're seeing, it's small amounts of community transmission. Michael, do you want to?
Yeah, anyway, just to say, I think that more broadly, I think the seasons are not with us. We're into autumn and winter, and we know that respiratory virus is spread more readily because of our behaviour. During autumn and winter, we spend more time indoors, less time outdoors, and I think that is going to be a challenge in the months ahead. We have, quite rightly, the executive decided to make significant relaxations from May. Associated with that, as Pam mentioned earlier, quite a number of the population, not all, have also relaxed in terms of adhering to the simple message of watching our distance, washing our hands, wearing face coverings. We need more people to download the Stop COVID NI app, and we need more people to, as Colin is doing, when they're advised to self-isolate, they self-isolate. If they need to get a test, they get a test, and they complete their period of self-isolation. And we're going to have to, basically all of us, hunker down hard for the next 6 months until we get to the spring. It's going to be a very, very challenging period ahead, as you said, Chair.
Okay, thank you very much. And Colin, just on behalf of the committee, to wish you well and your family well at what is a very worrying time. But that is good to hear of a positive example where the system is working, because it's going to be vital that the system holds up. Obviously, that's going to be key. Thank you, Chief Medical Officer, and thank you, Minister, for attending this morning, and we look forward to seeing you again soon. Okay.
Thank you, Chair. And again, Chair, can I just thank you and the committee for your continuing support in our messaging. While we have those siren voices out there who seem to want to just challenge for the sake of challenge, one thing that has been steadfast for our health services is the support of this committee, and also for challenging what we do, but also supporting the message that we need to get through to the general public of Northern Ireland. So thank you for the work that you continue to do.
Okay, thank you, Agus Moore, and all the best. Okay, members, thank you. Okay, members, so there are several items of correspondence from the department included under that's in relation to 5.2 of the coronavirus. Any other comments in relation to the Minister's input this morning, or anything else that members want to address or comment on at this point? We're all okay. Okay, thank you. So, looking then at item 5.2 relates to the 6th monthly review of the powers in the Coronavirus Act 2020. Have members any comment in relation to that document? Or members content to note pending ongoing scrutiny of relevant statutory rules, which we will obviously be doing on an ongoing basis? Okay, thank you. 5.4 is in relation to the step-down facility at White Abbey Hospital. Do members have any comments?
Sure.
Yeah.
I would have liked some more time to question the Minister on this, but given it was such a tight session, it wasn't possible. I mean, we asked the Minister to explain the rationale for picking this particular facility, and you know, so that we could scrutinise the reasons behind it. Now, I have to say they're very broad reasons there. We don't know whether there was a business case. I mean, there's talk about accessibility as one of the criteria that was used. I mean, if you come from Balik, it's not accessible, and this is supposed to be a regional step-down facility, so presumably patients might be coming from different hospitals, not just from the Belfast Trust. And I mean, there's not really enough information in there for us to do proper scrutiny on the decision that the Minister made, and I'm wondering if we should write back and ask for further information as to why other facilities were excluded, I suppose. I mean, it only mentions there that there was one other facility that was shortlisted, the Econ Exhibition Centre. Never heard of it, to be honest, but you know, if we're going to do a proper job of scrutiny, we're not going to do it on the basis of the information that the Minister has provided to us in that letter.
Yeah, thank you, Paula.
Thank you, Pat, for raising that. I raised, I think the last time the Health Minister was here, the fact that $250,000 was spent refurbishing and then stepping down the other step-down facility in the Ramada Hotel, and the Minister at the time had said, oh, actually that was the Belfast Trust did that, this is actually the Department of Health doing that. So there's a disconnect, but there's also a lot of money being spent, and the transparency around the decision making. I have some queries about the hotel that was picked for the nurses to stay in, because I hear that the tenders come in from other providers that was cheaper. So some of this actually overlaps with, I think, the audit committee. So I'm just wondering if we start maybe looking at ways in which we think that maybe money wasn't properly spent or decisions weren't taken properly and with due diligence. So I just want to put that on record.
Yeah, I also felt that the response back was inadequate in the sense that it was almost anyone would know those would be the broad issues you would consider when you were considering where services were being placed. I would have liked to see more details in terms of access times, what weighting was given to each of the criteria. So there was mention of accessibility, there was also mention of cost and other supports around it. So I think I certainly would have liked to see more details. So
Could I just caveat what I said by saying this might well be the best facility, you know, but we haven't enough information to carry out our scrutiny role comprehensively.
Yeah, Colin, you're on mute. You're on mute there, Colin.
Okay.
Yeah, go ahead now.
There we go. Can you hear me now?
Yes.
Yeah. So I just wanted to agree with that, because I represent a constituency that's had like significant cutbacks in services at the Down Hospital, and then residents within my constituency that utilise Daisy Hill. So we seem to be impacted by a cut in services, but there seems to be like a ring of steel that's going around Belfast, with Lagan Valley down the road getting enhanced services, White Abbey up the road getting enhanced services, hotels in Belfast being used for services, and that money that's been circulated within the system, and then there are other outlying areas that just aren't getting any additional services but are getting their services cut. So I think it's important for us from a scrutiny basis to be able to understand why these places have been picked and why constituencies such as mine are losing out in their health services during this.
Okay, so members are content we write seeking further detail in relation to the decision-making process around White Abbey and other similar facilities, that we want to know the criteria that's being applied. Orlia, did you want to?
Content on that issue.
Yeah.
coming after.
Do you want it on this issue or after?
No, after.
Okay.
Sorry.
Okay, so members are content with that. Thank you. Okay. Okay, Arlia, go ahead. That's.
Yes, sorry, it was just in relation to writing off to the Minister, just on the back of the briefing that we had there. I know he had says that he would provide the committee with the letter that he had sent to the executive just about some of the Brexit issues and the medicine supply. So, but just if we could follow up that's done. Thank you.
Okay. Thank you. Okay, members content then with those. Thank you. So moving on, we're now returning to the 3 SRs deferred from last week on further travel restrictions. Members, you will remember that we heard from officials last week on the evidence behind the regulations and the role of the Joint Biosecurity Centre. No further information has been provided to the committee as yet, although we understand discussions are progressing on relaxing some of the current restrictions on the sharing of data. However, we do need to take a decision now on these 3 SRs as we are approaching the end of the statutory period. Any decision we arrive at today would not prevent us from continuing to press on this matter, and I think it's important that we do emphasise to the department that we are determined that the information coming to this committee is of an adequate level for us to make good decisions and apply proper rigorous scrutiny. Miss Elaine Colgan and Professor Ian Young are available to take further questions if required, but I wonder what members' view is on that, given that we're not hearing that we have had a conclusion in terms of information being shared from the Joint Biosecurity Centre. Jerry?
Just a comment, Chair. I mean, I think it is disappointing we're not getting that information, and obviously members were making points last week and the week prior. I just think that when it comes to these issues, we obviously want to have as much information as possible. We want to make correct decisions, we want to scrutinise decisions and challenge them where necessary. And I just don't think it breeds confidence amongst the public where there is a rise in unwarranted scepticism. We should have the information in front of us. So I just think it's disappointing that that's not available again, Chair.
Yeah, and I actually would it be something that we should consider that we write to the department expressing our concern in relation to this level of information, along with whatever decision we make on the SRs, but that we write to the effect that the committee notes with concern the inability of the Department of Health to provide accurate and timely data. I think that's one of the key issues of it. Would people be? Another issue is limited evidence of the effectiveness of the monitoring arrangements. I think there's been very little feedback in terms of the airport stuff. Lack of clarity on the decision making between the DOH and this Joint Biosecurity Centre, which is a relatively recent development, and I believe it's unhelpful that information is sort of getting locked in there and not being able to flow through the system, and that's impacting the ability of the committee to complete its scrutiny role. Would members be content with that form of? Yeah. Mm-hmm. Okay, and then will we move on into our consideration of the SRs individually themselves? Members content with that? Okay. So SR 2020/193, this is the one that enabled a regional approach to be taken to removals and additions to the list of exempt countries and territories in respect of post-travel self-isolation requirements. It also thereby excluded the Greek islands of Lesbos, Tinos, Serifos, Crete, Mykonos, Santorini and Zakynthos from the list of exempt countries, and it amends the list of specified competitions relevant to the exemption from the requirement to self-isolate for sportspersons, for elite sports people. The Examiner of Statutory Rules has reported that this SR was laid in breach of the 21-day rule, but that she is content for the Department's reason for that, and this rule is subject to negative resolution. So, have members any further issues they wish to raise in connection with that specific rule? No. If not, can I ask members to agree formally that the Committee for Health has considered SR 2020/193, the Health Protection, Coronavirus, International Travel, Amendment Number 9 Regulations, NI 2020, and has no objection to the rule. Are we agreed? Okay, we're agreed. And members have agreed that we write to the Minister expressing our dissatisfaction. If moving on then to SR 2020/194, The Department advises that this SR adds the Azores, Madeira and Sweden to the list of countries exempt from the post-travel self-isolation and removes French Polynesia, Hungary, Portugal and Reunion from the list of exempted countries and territories. The Examiner of Statutory Rules has reported that this SR was laid in breach of the 21-day rule, but that she is content for the Department's reason. The rule is subject to negative resolution. And have members any further issues in regard to that individual one?
Sure, just a comment. I mean, I don't know if we can make this a general rule, but I mean, I think we got this SR was it 2 weeks ago or maybe a bit longer, and since then, you know, my understanding is the Swedish infection rates has rapidly increased. So, if I'm correct, we're kind of being asked to take a decision based on the R rate and infection rate 2 weeks ago in Sweden, whereas it's shot up. So if there's countries where there are high rates of infections, I mean, I think it is more incumbent that we have the up-to-date, you know, as best as possible of the R rate, because we could be, in effect, endorsing sort of people from Sweden not isolating, and there could be further restrictions in Stockholm and I believe other places, which seems to me at best disjointed, if not worse. So I think if we can sort of relay that to the department as well. I don't know how we stipulate that as a general rule, but it's something that's just jumping out at me, to be honest.
But I think I had mentioned in the earlier one the timely and accurate information, which hopefully will cover that. Hopefully will cover that, Jerry. Okay. Any other comments on that one? No. Thank you. So. If not, then no further comments, can I ask members to agree formally that the Committee for Health has considered SR 2020/194, the Health Protection Coronavirus International Travel Amendment Number 10 Regulations 2020 and has no objection to the rule. Are we agreed? Agreed. Thank you, members. Moving on then to SR 2020/200. The Department advises that this SR adds Singapore and Thailand to the list of countries and territories exempt from the post-travel self-isolation requirements and removes Guadeloupe and Slovenia from the list of exempt countries and territories. The Examiner of Statutory Rules has reported that this SR was laid in breach of the 21-day rule, but that she is content for the Department's reason for that. The rule is subject to negative resolution. Any further comments in relation to that specific rule? No. Thank you, members. Can I ask then that members agree formally that the Committee for Health has considered SR 2020/200, the Health Protection Coronavirus International Travel Amendment Number 11 Regulations NI 2020 and has no objection to the rule? Are we agreed? Agreed. Thank you. So moving on then to any other business. Do members have any other business today? Yes, Jerry?
Chair, just for your information, and it may form our future work discussions, but I've been informed that the South Eastern Trust has issued a performance notice at the Murray Manor nursing home, and apparently there's more whistleblowing reports, concerns coming through, so I just think it's important for the Chair and the committee to know that. Obviously it was we've been talking about care homes quite a lot, but I think it seems to be from this news that certain lessons may not have been learned, but I think it was important for you to know, the committee to know, Chair, and it may form obviously part of our work in the future. Yeah, and we are conscious that is a key part of our work in the time ahead, so thank you for that information, Jerry. I think that is certainly useful. Okay, members, date and time of next formal meeting then. The next meeting will be held on Thursday, 8th of September in the Senate chamber. Would members be content that we, over the next number of weeks, look at a 9:30 start in light of work pressures and in light of people having additional meetings to go to? Maybe it will help us to get a head start. So if we could go then with that next meeting, Thursday, 8th of September in the Senate chamber at 9:30. Thank you, members.
This is the Northern Ireland Assembly.